Hello, everyone. We're so glad that you joined us for another edition of the LymphaPress educational webinar series. It is a special month. It is Lymphedema Awareness Month. And as you are logging on, we're just so glad that you're giving some time out of your very busy day to join us. And we'll do some housekeeping items first before we get into what I believe is a very groundbreaking presentation. And by the way, if you're here, tell us in chat where you're from and where you're joining us from. We're delighted to welcome you. A little bit of housekeeping. Everybody who has registered for this webinar will receive a link to the replay. We get it. There's usually so much information involved. It's hard to get it in one sitting. So you'll get a chance to watch it again. Once it is edited, uploaded to YouTube, you'll all get a link if you registered for today. If you have questions, Karen Ashforth would love to answer them, and we invite you to put them in the Q&A. We'll wait until the end of her presentation and we'll go through as many of the questions as we possibly can. And before I interview and introduce Karen Ashforth, I want to make a couple other quick introductions. Since we all last got together, we made an announcement that was groundbreaking for us at LymphaPress and so exciting to the world of lymphedema and lipedema. Dr. Karen Herbst is our medical director, and we welcome you, Dr. Herbst, as an avid listener to what we know will be a great presentation today. Great to see you, Dr. Herbst.
Thank you. Excited to hear you, Karen.
Yeah, and our president, Eric Ansart, is also here, and we always welcome you and are so glad that you're here. We are Team Karen Ashforth. We enjoy what you share so much, and it's always so valuable. So without further ado, I will let my fellow panelists disappear while I introduce Karen Ashforth. Now, today's subject, I love this title, and I think that's what grabbed so many people, Karen, which is, why do some of my patients never fully get better? LymphaPress is in the business of helping people's lives become better and to better manage their conditions. And this is such a compelling title because we all want to see patients get better. And the importance of connective tissue and dysautonomia syndromes in lymphedema and lipedema treatment is the subtitle. I know that you have a lot of material to cover, but I do want to say that Karen has practiced as an occupational therapist for, it cannot be over 40 years, Karen, impossible. You have specialized as a board certified hand therapist, and that led to Karen's interest and specialization in treating lymphedema and fibrosis about 20 years ago. She speaks frequently at academic, clinical, and professional settings, performs clinical research, and publishes nationally and internationally. I know that Karen put her heart and soul and so much research into this presentation. So I am on the edge of my seat as well as my colleagues, and I will hand the baton over to you, Karen, and say, take it away.
Thank you so much, Brenda. And I'm really so excited to be doing this presentation because over the past few years, I have been recognizing these syndromes more and more in my practice. And these are people that have mystery symptoms, and it affects their lymphedema and lipedema. So I've been exploring these syndromes and taking deep dives into the literature, and all of this has given me tools that have allowed me to help my patients on a deeper level. I am so excited to be sharing this information with you. So without further ado, I thought this would be an interesting way to get your attention because we're going to be talking about something that's identified in up to 90% of people living with lipedema. What could be triggered by chemotherapy and cause chronic swelling as well as a myriad of other symptoms? What is observed with people living with Dercum's disease? And what produces swelling that's related to higher resting venous pressure, even with patients that might have upper extremity diagnoses for lymphedema or lipedema? So why are these syndromes not being recognized in lymphedema and lipedema patients? That's why I really am so very, very happy to be presenting this information as an introduction. And there's way more past this. By the way, I should just say, in case you hear a little faint bell in the background, I'm taking a little break from my clinic practice today at St. Joseph's, and they've been doing fire drills all morning. So if you hear something, that's what it is. Okay, so without further ado, this is the symptom triad that I'm going to be talking about, and I'm going to go over each one and how they relate to each other. So I love these graphics because the hypermobile Ehlers-Danlos syndrome has Gumby as a mascot, and mast cell activation disorders has a roaring, angry lion as a mascot. And then postural orthostatic tachycardia syndromes has a fainting lady as a mascot. And I've chosen these icons just to kind of help anchor. If this is new to you, some of you already know about this, but for people that are getting kind of a first glance at this, I'm hoping these icons will help you identify the constellation of symptoms that go with each syndromes. So I love the Venn diagram because it shows the overlap, and they all have inflammation and swelling in common. The hypermobile Ehlers-Danlos tends to be more inflammatory with pain and swelling in the joints, prone to injuries, often complications post-surgery. The mast cell will see a lot of inflammation, pain and swelling, which is, you'll see a slide later where I talk about whack-a-mole. It can be very migratory, it can be very elusive and aggravating because it can show up in any system of the body. With POTS, we see a lot of orthostatic swelling, so mainly the lower body and ankles, and it's common to have migraines and autonomic nervous system disruption. So when we look at how the three overlap, the reading that I've done say that they are all dominantly inherited with elevated tryptase, but there's a questionable phenotype connection. They're still working on the research on that. There's definitely an autonomic nervous system component that can tie these together, chronic inflammation and pain, connective tissue abnormalities, skin and GI issues, no known cures, poorly understood, underdiagnosed. And the kicker is that it is possible to have one or more of these at the same time. That's why they are real related, and that's why I'm presenting this as a group. So this is just at a glance, some definitions. We'll talk a little bit more about EDS, but it has 13 subtypes with inherited collagen abnormalities, the hallmarks of which for all of the EDS types are fragile tissues, skin and joint hyperextensibility, but these symptoms are absolutely pronounced in the hypermobile type of EDS. It is the most common subtype. It's often associated with the mast cell and POTS. And as I mentioned earlier about what is associated with lipedema, I'll just kind of tease you a little bit because I've got an amazing slide coming up on that. In terms of mast cell activation syndrome, there's a number of disorders with mast cells, but we're just going to talk about the syndrome today because that is more common and more generalized to reach more of the patients that we have. It's an overactive or inappropriate activation of mast cells, which live in the connective tissues, and they release histamine and heparin. And we will learn how that wreaks havoc with the body when it is activated to an exaggerated amount. The postural orthostatic tachycardia syndromes have a phenotype of hyperadrenergic, neuropathic, or autoimmune pathophysiological processes. That's a mouthful. So that's just an intro, and I'm going to be giving you a few more details in a bit. So let's focus on EDS. It's a group of connective tissue disorders that affect collagen, and it's a multi-system disorder. The hallmarks, which I'll be illustrating in a minute, are fragile tissues, joint and skin hypermobility. It is inherited. It's underdiagnosed, and there is evolving diagnostic criteria. And because there's no known cure, it's all about symptom management. Visually, these are the hallmarks. This can impact our lymphedema and lipedema practices because with fragile tissues, it means the wounds that could possibly happen are not going to heal as normally as they should. And skin can be very hyperextensible, joints as well. So most medical professionals are not trained in the assessment of EDS. And genetic testing is the gold standard, except for hEDS, because they're still figuring out the genetics. But an early diagnosis helps to reduce symptom severity, prevents complications, and improves quality of life. There's also an overlap in symptoms between the subtypes. So many of our audience are lymphedema and lipedema therapists and maybe even patients. And if you recognize some of these things going on, you may be able to share resources with a physician who can help with diagnoses. But I want to say that not all physicians are going to know what this is. So it might mean some education. This is just a list of all the subtypes. You can see that, that they span all different systems. And now we're going to focus in on the hypermobile type. So as I mentioned, with the tissue fragility, it's easy wounding, poor wound healing. The scars can be dystrophic. It can also be easy bruising. What else does that sound like? And GI bleeding. Skin hyperextensibility is tested by pulling the skin to resistance, and it stretches easily, snaps into place. By the way, the skin quality is often very different. It's very soft and velvety, unusually so. So if you see hyperextensible skin in 3 or more areas, the distal forearms, the dorsal hands, the neck, elbows, or knees, that could be a tip-off. And joint hypermobility. So this is where the range of motion exceeds normal. There's often lax ligaments, tendons, and joint capsules. So that creates joint instability, which can lead to injury. And this affects arms, legs, the spine, and it's common to see muscle spasms and hypertonicity, which then in turn create tension and pain because the muscles are splinting, trying to keep the joints stable. We're going to learn in a minute a little bit about the BEIGHTON score assessment tool, which is a great screening tool to look for hypermobility. I want to just say a word first, though, about the hypermobility spectrum and say that there is a lot of attention being given to hypermobility, and there are a lot of different syndromes that have been identified. And so someone may have hypermobility and not necessarily have the hypermobile Ehlers-Danlos syndrome. So I wanted to just throw that out there so that you could be aware as you're taking a look at things. In terms of the spectrum, the incidence is estimated as high as 57% of the general population. And many people are going to be asymptomatic. There are no known genetic markers for hypermobility in general. The phenotypes can be similar. The clinical presentation can be similar. A lot of research going on. But hypermobile EDS has some very specific criteria, which I'm going to share with you. First, let's just talk about what you might see in a patient that has hypermobile EDS. So it is the most common EDS type, and we will definitely be seeing hypermobile joints. They could be subluxed or dislocated easily. There are often proprioceptive difficulties, and proprioception is how we navigate our way through space. And so people with hEDS might feel more klutzy than the average person because they don't necessarily have the relationship with the outside world and objects in a normal way. And that's something that we can work on in therapy. There can be postural dizziness, and that plus the hypermobility and the decreased proprioception can lead to injuries. So people with hEDS are very injury prone. In addition, there's a lot of possibilities for inflammation and pain. It can be localized to a joint, or it can be more diffuse, especially if you have muscular splinting. There can be swelling. and GI symptoms. And the skin issues, as I mentioned before, can include fragility and poor wound healing. So, drum roll, please. Here is my bombshell. And I want to acknowledge Dr. Karen Herbst for sharing this new unpublished data with me that Dr. Samaro in Spain has identified a 90% incidence of hEDS in his lipedema caseload. That is the highest number we have ever seen. And Dr. Herbst herself has acknowledged that over 50% incidence in hypermobility disorders in lipedema, mostly hypermobile EDS. Beltrain identified that the connective tissue changes in hEDS can contribute to tissue deformations in lipedema stage 3. So this is, I think, for anyone working with lipedema patients, critical information to be able to help guide treatment and referral for your patients. This is just a one-page form that has all the criteria for hEDS. We'll just be talking about the first criteria, which is the BEIGHTON score. But if you are interested in this information, we can throw it in the chat, or you can also request my slides. And this link takes you right to this form that has all the different criteria in diagnosing hEDS. This is the BEIGHTON score. So if you get nothing else out of this talk, I hope that you can start using this in your clinical practice, because this will tell you so much. You basically get a point for each body part. So we've got left and right sides of the body with the fingers, the thumb, wrist, the elbow, and the knees, and then the spine counts as 1 point. So it's a possible of 9 points total in this. And I've given you the specifics. This is where the patient is going beyond the normal range of motion. And this just shows the scoring, a possible score of 9 between two little fingers, 2 wrists, 2 elbows, 2 knees, and 1 spine. So if the score is above 6 in pre-puberty, because younger people tend to be more mobile, from puberty to age 50, 5 of those joints, and over 50, 4 of those joints would mean a positive BEIGHTON score. And if the score is 1 point below the age, then talking about past joint hypermobility can be helpful in making the big picture. And this is another link that we can drop into the chat so that people have access to this. These are from Ehlers-Danlos.com, which has a wealth of information, and I'll be citing them in my references. So if there's no known cure, how do we manage these symptoms? We have to look at chronic pain management modalities. It's very, very helpful pre-surgery to know that these symptoms could possibly interfere with wound healing, with how reaction to anesthesia, bleeding, scarring, and there can be some horrendous pregnancy complications with mothers who have hEDS. There are a number of different approaches for GI treatment, which is a common symptom: skin protection, counseling, education, and certainly PT and OT. So let's talk about the injury cycle. If we've got an unstable joint and the range of motion is hypermobile, so oftentimes people will use the joint at the end range. That affects postural habits in all types of function, including walking, mobility, use of arms. And adding in the proprioception deficits, we end up with increased joint stress and fatigue, which then creates pain and sets someone up for an injury. So in terms of therapy, we use a multimodal approach. We're looking at pain and inflammation management and specialized programs that can help to increase joint stability. So it's not about increasing range of motion, because that's usually beyond normal. It's about strengthening the muscles on either side of the joints, increasing the core stability so that the joints are better protected. Neuromuscular reeducation, proprioceptive training, prevention of injuries, even splinting unstable joints. And I wish that this lecture were 5 times as long, because I could give you slide after slide of different splints, concrete examples of some of this. So I'm just giving you a little intro taste. But compression is also a significant treatment modality that can help, because if someone has pain and swelling, working with compression can also even help with stability and proprioception. So we want to prevent injuries. We want to look at posture and core and joint stability, proprioception, especially in the knees and the fingers, look at range of motion, motor control, targeting some exercise. And I've got a really great couple of references. By the way, I probably pulled over 100 articles for this lecture. And I've kind of given you the real pearls that I think are most helpful, but there's all kinds of information that's coming out on this. Splints and types of footwear can also help with preventing injuries, helping stability. So protecting the skin from injury, from the sun, from sharp objects, basically lowering risk factors by avoiding smoking, corticosteroids, and NSAIDs, sun protection to protect that fragile skin, and regular skin care, and vitamin C can also be found to be helpful. In terms of GI, it has a high incidence in the hypermobile ADS, and it is underdiagnosed. And there is such a possibility of mast cell and POTS that there can be kind of a combination that can attack the gut. And that can show up as esophageal dysmotility, GERD. You can have problems in digestion that's too fast or too slow, leading to irritable bowel syndrome, nausea, abdominal pain, diarrhea, chronic constipation, and pelvic floor dysfunction. So if any of these symptoms are coming up in conversation, this is a real important thing to address. And GI can be compounded by pain and other medications. Particularly things like antibiotics, which can strip the gut of good flora. So I'm going to give you a case example of a client that I saw a couple of years ago who is an 11-year-old boy. His allergist diagnosed him with hypermobile EDS, and he has had a lot of injuries in his life. And he came to me because he had a sports injury. He had a left anterior cruciate ligament tear in his knee. He was 3 months post-repair, and the range of motion looked great, but he could not get that swelling down in his knee and his leg, and his knee pain was pretty high. He was being seen by a physical therapist for rehab after surgery. And so they had him in a conservative treatment program for 3 months and a stabilizing brace as well as exercise. So they were doing all the right things, but his swelling and pain just were not getting better. So when he came to me, I did a CDT program. I used a low-level laser for his scar tissue. This is him, by the way. And he was using the 20 to 30 thigh high, which he wasn't using that frequently. They had given it to him, but once he started using it regularly, then his pain went down from 5 to 7 to 4 to 5. And then I added a quilted leg sleeve with a Velcro wrap over it that he wore at nighttime, and his pain went down even further. But he was having problems performing self-MLD because he had a lot of wrist pain because he had hypermobility in his wrists. And as is common, oftentimes other family members will have hEDS as well, and that was the case in his family. So no one was able to really do the MLD that he needed to decongest his knee at home. So I got him a lymphopress pump and a single leg sleeve. He started using that at the same time that he was wearing his quilted leg sleeve, and his knee pain decreased dramatically, as well as his knee circumference. So that was a real game changer for him. And I no longer see him, but it's something where I advised him to hang on to this equipment, that, you know, things may have healed, but if you have another injury in the future, you may need to pull this in. So these are some recommended resources if you want to know more information about EDS or recommend this to your patients. And next, we're going to move on to mast cell activation syndromes. And so, as I mentioned earlier, the mast cells are in all of us, and they're found in the connective tissues, and they produce histamines, which are important in immune defense and inflammatory conditions, and heparin, which is an anticoagulant. But they can be overactive. And if there's an increased production and an increased release, that can create a systemic reaction that ranges from mild to life-threatening. A lot of times my patients will mention anaphylaxis, either to food, insects, or medications. And that is a huge red flag to me. And I'll start asking a few other questions. There's other symptoms that we commonly see in mast cell activation syndromes, commonly allergy type reactions, which can affect the eyes, the nose, the mouth, and the throat. There can be cognitive and mood reactions. We can see fatigue, insomnia, definitely swelling, and some interesting, I see a lot of cysts and fibrotic cysts in patients that have mast cell activation syndromes with both lymphedema and lipedema. And it's a different presentation than I see in patients that don't have the mast cell. It's real interesting, and I'd love to talk about that further. Fibromyalgia, pain, headaches, definitely all kinds of GI symptoms, and skin. Weird itching, hives, rashes, welts, eczema, flushing that sort of comes and goes, or can be just, you know, there all the time, and poor regulation of heart rate, blood pressure, and body temperature. I've been reading some very interesting articles recently that have linked mast cell activation to long haul COVID. So this is an area that is emerging in treatment that I'm following very avidly, because I think we have the potential to help even more people with this. So whack-a-mole is basically the theme for mast cell activation syndromes. They're migratory, they can wax and wane, they can vary in how severe they are. The stimulus can be very reliable, like a certain type of food or a chemical, or they can be unpredictable. And there can be compounding emotional and physical stressors that can make things worse. So because this is so insidious, there's some complex lab testing that's needed to be able to make a definitive diagnosis for mast cell activation syndromes. Just, I wanted to dedicate a slide to the cognitive emotional because it can be so frustrating and people can feel so out of control. So sadly, no known cure or standards of care. There's a lot of information out there, but the symptom management is so highly individualized. It's not a cookie cutter diagnosis. Commonly, there will be over-the-counter and prescription antihistamines, other medications and supplements that will be recommended, and certainly education, counseling, physical and occupational therapy to increase the quality of life and treat pain, fibrosis, comorbidities, especially swelling, and avoiding triggers such as stress, identifying dietary triggers, chemicals, and mold exposure is big for mast cell problems, infections, altered microbiomes, and some people just even get triggered by tape on the skin and have to be very careful about what they use. I also have been working with a PhD dietitian who is doing intestinal permeability treatment with a number of my patients. And so I throw that in there because that's something that I think can be incredibly helpful in managing symptoms. So talking about dietary, the triggers can be very individual with different responses. We know all about common anaphylactic foods like shellfish or peanuts, but what about lettuce? What about offbeat foods that are unique just to a particular person? Oftentimes people who have mast cell disorders have to regulate the amount of high histamine foods that they eat because that can stimulate more release of histamine. Fermented foods can be problematic, moldy foods such as cheese, and some people even have trouble with leftovers. Some people have to freeze food after they make it because if it's in the fridge for even a couple of days, it can cause a reaction. There can also be microbiological contamination. So you can see that this is it's a lot of different things that we're looking at. And some people may have dietary triggers, some people may not, but I think it's an important thing to keep on our radar. Fibrosis, as you guys know, this is a topic near and dear to my heart, and mast cells play a key role in skin fibrosis, and they are increased in fibrotic tissues. So there's a lot of work being looked at in terms of how we can block the mast cell activation to reduce inflammation and scar formation without weakening the healing wound. And then again, this is out of the scope of today's lecture, but I have some real specific techniques that I've been using with people who have combinations of lymphedema or lipedema and mast cell activation syndrome. So I'm going to give you a case example. This is a 56-year-old woman who has lipedema, and her anaphylactic reaction is to eggs and chicken. And her doctor had prescribed antihistamines and medication, and she was complaining about alternating diarrhea and constipation, swelling in her abdomen and legs, and constant lower body pain, 6 to 8 out of 10. She also had painful pocketed swelling in her thighs. So I believe this to be the type of fibrosis, the nodular type that we see with lipedema, but it was even worse. And she'd had prior treatment. She had a conservative home program. She was doing manual lymphatic drainage and wearing her compression, but look at that pain level. So I referred her to a nutritionist, and she lost 25 pounds and her bloating went away. And she actually discovered a few other things that she was allergic to. And we did some anti-fibrotic treatment to the pockets of swelling and fibrosis in her thighs, and we're able to get that pain down to 0. Now, it's a whack-a-mole kind of situation because they came back, but I taught her how to treat them at home. And so anytime it starts to reoccur, she's got the tools to treat herself. I got her a lymphopress pantsuit, and her lower body pain went down. Huge. I mean, look at this. This is someone that had 6 to 8 out of 10 pain, even with a home program. And we got her pain way down, as well as reducing the circumference in her legs and her abdomen. So this was a huge success story. And I've seen a number of patients with lipedema, with mast cell, and hypermobile EDS, and even some POTS. So it's very individualized. And that's why having this awareness, having these tools, pulling in resources is so important in treatment. So now we're going to move on to some recommended resources. These are my top 5, but there's lots of information out there. And now we're going to talk about postural orthostatic tachycardia syndromes. And my symbol here is the fainting lady, because dizziness and fainting can be part of this. So with this, we see a low blood volume and low venous return and an increased heart rate in an upright position that doesn't seem related to blood pressure. So it's not like the blood pressure drops consistently with these people, but the heart rate goes up. And so it's usually, to diagnosis, it's 30 beats per minute increase with adults and 40 in adolescents between lying down and being upright. And there's even a protocol for using a tilt table to gradually bring someone to an upright position. So a lot of these people like to lay down because their symptoms are better. And same thing with the fainting and dizziness and dysautonomia. These can all feel better when someone's laying down. And there is often a high resting venous pressure, so a venous insufficiency and orthostatic swelling. And people could have hyper or hypotension or a fluctuation of both. So this is a chronic condition. We see this 5-to-1 in favor of women, primarily in the ages 15 to 50. And what caught my attention is that I had a breast cancer patient that you'll meet at the end when I do a little case study. Her symptoms started the first day she had chemotherapy. And I've since pulled a whole bunch of articles that verify that. By the way, chemotherapy can also affect mast cell activation syndrome. I didn't talk about that because I didn't have the case study, but this heavy metal toxicity, infections can trigger all kinds of things. And certainly in POTS, they can do that. There can also be a gradual onset. We've seen this observed in Dercums, and the major influences tend to be hormones, histamine, and immunological. So see that little overlap, histamine with mast cell. So these are some of the things we'll see. If you've got patients coming in that are complaining about a racing heart, they feel better laying down, they're fatigued and can't tolerate activities very well, pain, especially migraines. And we see an overlap with myalgic encephalitis and also chronic fatigue syndrome. Other autoimmune issues, there can be skin issues, GI issues, cognitive, sleep, shortness of breath, hyperventilation, increased sympathetic nervous system activity, body temperature regulation issues, and emotional distress. But see all the potential overlap with mast cells. So what's what? Well, what we want to do is basically, those of us who are clinicians are going to treat symptoms and refer to people who can help with other medical treatment, such as medication. So in the clinic, I use compression, and I'm going to talk a little bit more about compression and diaphragmatic breathing. Also, trigger point treatment is helpful symptomatically. Definitely antifibrotic treatment and ADL tools, possibly changing diet. Exercise is graded starting in horizontal position and moving to upright. These people may benefit from certain medications and hormones, definitely from stress and pain management. And my cool discovery that I just love telling people about is barometric awareness, because we know that air pressure is like a big old compression garment on the whole body. And so when pressure drops, we have less external air compression, and that can affect swelling, but it can also affect things like migraines. And so I've discovered an application that can be used on the phone that can give people notifications when there is barometric pressure changes. And there are special earplugs that people can wear, notably when you fly, that equalize the pressure in the ears, that are very helpful with migraines. So with POTS, it's important to expand the blood volume and get enough fluid every day. And I'm very cautious about sodium with people that have swelling. So I say start really slow, see if it helps you, build it up, monitor your swelling. It can be in the form of salt, electrolytes, or even medication. And then compression that helps to decrease the venous pooling in the lower body. So the compression does reduce the venous pooling during orthostasis, and ideally, it should cover from feet to the xiphoid process in the chest. I have some patients that just use knee highs and it's fine, but some people need to compress the abdomen, and an abdominal binder, either with the knee highs or in combination with the tights, can extend the compression. And then there's physical measures you can use, like squeezing a ball between your legs, crossing the legs, squatting, negative pressure breathing, muscle pumping that can help, as well as sleeping with the head of the bed elevated. I teach diaphragmatic breathing to every single one of my patients. And whatever you use, we know that it increases lymphatic velocity and it helps with venous return. So this is key with patients with POTS. So I'm just offering this. This is an article where they researched different types of breathing and came up with this, with the 2-second inhale, 2-second exhale, and then a second control pause, which means just holding before the next inhale. And I love the box breathing, which is 4-4-4, but whatever slows the breathing down and engages the diaphragm is very, very good. Exercise is really key, because many people are deconditioned because it's difficult to exercise in an upright position. So as therapists, we can supervise training, beginning with horizontal exercise and activities such as rowing, a recumbent bike, or even swimming, and then progressively increase the activity to an upright posture. Also, fall risk is very important to throw into the mix. So here's my example. This is a woman who completed her breast cancer treatment 6 years ago. And this is the one whose symptoms started with the first chemo appointment. So she displayed elevated heart rate when she went from lying to sit or stand of elevation of 35 beats per minute. She frequently complained that she was dizzy. She had a lot of anxiety. She had lymphedema symptoms in her right upper quadrant because of the breast cancer, but also in her ankles. She had a lot of pain in her right chest and armpit, which was constant, 5 to 8 out of 10. That is a high level of pain to live with. And even worse, she had constant migraines, which she rated as 6 to 8 out of 10. So she had prior lymphedema treatment. She was wearing an arm sleeve. She was doing manual lymphatic drainage. What did I do with her? Well, I started her with a lymphopress jacket and appliance, and look at how her pain dropped. This was such a game changer for her because she just wasn't getting it with the MLD and the compression. I turned her on to the phone app and the barometric pressure equalizing earplugs, and her migraines stopped being constant and the intensity went way down. Look at this. This is dramatic changing. It's funny because I'll come into the waiting room, she comes back for tune-ups here and there, and she'll be doing her diaphragmatic breathing, and she practices it all day long. That has helped her so much. I also got her some compression tights, and that stopped the dizziness and fainting because it helped the orthostasis. I also recommended counseling for PTSD because the cancer treatment really shook her, and to be able to have all of these negative symptoms that she was dealing with from the start of chemotherapy, she was just really not a happy camper. And so she has had some benefit from that as well. So here are some resources for more reading about postural orthostatic tachycardia syndrome. And with that, I would like to take some questions. And keep in mind, I'm not an expert. If Dr. Herbst is still here, she probably knows as much or more than I do about these things, because I know she sees these in her practice, and would love to just see if anyone is curious or has, a desire for a little bit more information about what I've just spoken about.
Well, the whole time you were talking, Karen, people were saying, can I have the slides? Yes, you had said that we could make the slides available. This is such amazing information, and I appreciate the research that you did and the heart. What I love about you and the work you do is you so care to see patient outcomes and results. And every time I saw one of your slides that said pain reduced, it was just like my heart leapt. And I think for those that are on today's webinar too, there's some excitement and the ahas of, ooh, maybe this is what could help one of my patients. So I will get to the questions right now. One that Dr. Herbst had before she did have to leave because she has a patient today. And that was, any recommendations for treatments for leaky gut?
Oh, absolutely. So there's all kinds of protocols, and I'm not a nutritionist, so I'm not qualified to treat this directly. But I think that there are many nutritionists out there who are highly qualified to help with leaky gut. There's all kinds of protocols and supplements and ways of helping to heal the gut. And I've seen this in my caseload, that when people have worked on this, this helps some of the other symptoms calm down. Because I tell my patients, with the gut, if mama ain't happy, nobody's happy. So addressing the gut is key. And I think that that's an area that is very accessible to treat. And if you don't have any particular nutrition background yourself, then I encourage you to find a great nutritionist that your patients can work with.
Great. Well, there's buzz also about these earplugs. Nurse Dina and several others want to know the brand name of the earplugs you mentioned.
So okay, first off, let me tell you about the app, which is called Weather X. So it's the word weather and then capital letter X. And that is available for both Android and iPhones. And I'll tell you, they recommend a proprietary blend of earplugs, which is totally unnecessary because they're expensive, and they recommend that you don't reuse them. And I recommend a brand that's called Earplanes. It's just like,
the airplanes, but earplanes.
Yeah, airplanes. And I use them every time I fly because I often have congestion and my ears don't hurt when there's the landing and takeoffs. So those can be used over and over and over and over again. So that's the combination that I recommend to my patients for any kind of migraine or earache or anything that could be affected by barometric pressure change.
Fantastic. So Mildred Nacier is here. Mildred, we're so glad you joined us today. And she wants to know, would a rheumatologist be the one to prescribe the mast cell test?
So a rheumatologist could very well be someone, and a lot of allergists are hip on this, some internal medicine specialists. So it can be a variety of different specialties that can be helpful with this.
Okay, so I'm hoping I don't butcher this word. A question came in regarding your 56-year-old female patient, curious to know if she ever had taken fluoroquinolone. Did I say that properly? Fluoroquinolone, antibiotics?
Sounds good to me. I don't know that part of her history. So I can't answer that question. I'm sorry.
So I want to talk about pain for a minute, because I've been embedded in the lipedema community for about 2 years now. And, it's not about reduction as much as it is quality of life. And this aching pain that these women live with, it's perceived that about 11% of all women have lipedema, and yet it remains so undiagnosed. And I loved how the LymphaPress produced such a reduction in pain. I am reminded of a woman I talked to. Her name is Kelly Maynard, and she said, I didn't realize that I lived with such a constant aching in my body until I started to use the LymphaPress. What is at work here that is reducing that pain? Because we've got studies after studies. There was a Denmark study that said 87% of patients that used the LymphaPress reported pain levels reduced. What is happening when they are using our LymphaPress pneumatic compression that is alleviating the pain?
So that is such a great question. And I love the fact that pain can be managed in sometimes a very easy way. So what is happening is a number of levels. On a physical level, because there is less swelling, then there's less pressure on the joints and the tissues that can cause pain. There's also an autonomic benefit, because I tell you, my patients that are using pneumatic compression, they tend to fall asleep. It is so relaxing, and it's a place of safety. It's a refuge for many of my patients where they have their time and they can practice their deep breathing, and it helps with all kinds of symptoms, but especially with pain. And there was even a study that was done a few years ago in Israel. The chief author is Honigman, where they actually looked at LymphaPress and they looked at pain, and they saw pain reduction. And there was a mention about autonomic benefits. So I think when we're looking at the benefits of pneumatic compression, it goes way beyond swelling. Goes way beyond fibrosis, and it gets into those quality of life issues. So, yeah.
You know, and I know that you are an impartial presenter. I am not an impartial host, because I know not all pneumatic compression is created equal. And you spoke to the emotional distress of some of these conditions. I can only imagine that that is compounded if you're prescribed something that isn't easy to use. You feel overwhelmed and you feel like, oh no, yet another failure. And I think that's why the LymphaPress was created, to be user-friendly. It's built for real life, the life of the actual patient who may not be mobile, who may be hypermobile, who has all of these different conditions. So I'm so glad you spoke to the psychosocial and emotional component of what these patients face as well. And that the one patient you actually recommended post-traumatic stress disorder therapy.
Yeah, yeah. And actually, I should just mention, Brenda, that I use a lot of different kinds of pumps, because depending on my patient's insurances and needs, I want to be aware of everything that's out there. But you'll notice that the 3 case examples use LymphaPress, because that was the most appropriate treatment for that individual person, for a lot of different reasons. And I thought, well, I'm doing this for LymphaPress. Let's talk about what LymphaPress is doing for people with these syndromes. And but I want people to know that I play the field. I do everything, but I keep coming back to LymphaPress because the features really seem to be at the head of the pack in terms of being more versatile and superior treatment for many of my patients.
Well, we love hearing that, and we hear it from the patients themselves over and over again. We have files, binders, hundreds and hundreds of patients who have said, I couldn't walk before, I couldn't play with my grandchildren, I couldn't garden, and now I can, because I'm using the LymphaPress to manage my condition. You know, I want to also mention, Nurse Dina asks, does insurance cover LymphaPress? Great question. We are in network with most insurances. So the best thing to do is connect with your local representative. In fact, if you email me, bviola@lymphapress.com, and I'll put my email in the chat, I'd be happy to connect you with your local compression therapy consultant that provides LymphaPress. They'd be happy to in-service you, show you the different features, the different garments. We've got a pump for every patient, and we've got a garment for every body, even up to the LymphaPod, which can handle upwards of over 400 pounds. Patients have solutions with the LymphaPress. So Dina, we will definitely be reaching out to you. Another thing, because I want to squeeze as much of your brilliance as I can out of the hour we have, Karen, you talked about those triggers that can often be as mild mannered as you would think lettuce is? How do people get to the bottom of these issues? Food sensitivity tests?
Yeah, that would be a great way. A lot of people can also do elimination diets, and I'll recommend while they're waiting to get in to see the nutritionist, that they may want to just target the chief offenders that many people have problems with. So wheat, dairy, corn, soy, peanuts are real common things. And I'll say, just take them out of your life for a week. And then after a week, eat a bunch of them and see what happens, because that can sometimes be a dramatic change. The other thing is that, since we're talking about lymphedema and lipedema, there has been buzz about gluten as an issue with many people that have primary lymphedema. So I think it's really observed whether patients are having digestive issues. And a lot of patients, it's just normal for them to be slightly nauseated all the time or to have abdominal bloating. It just has become a normal, which can be changed.
So I think it's also part of what I'm hearing too is it's not one size fits all.
Right.
What may work for one patient may not for the next, but try everything that's at your disposal.
Well, and find someone who's knowledgeable to help guide, because that's why I wanted to do this lecture, is because for those of you in the audience who are clinicians, this is just the start. And there's so much out there. But being able to have this information, your patients will be talking about something and it'll trigger something, and then you may ask 5 other questions. And that's how that patient with the POTS that I was treating, she was a breast cancer patient, but she had leg swelling and she had these migraines. And I have to ask all my patients what their pain level is each day that I treat them. And her pain was so consistently high. And I would ask where it was, and she would talk about a migraine. It's like, oh, let's connect a few dots here. Try this, this, and this. And I wrote a letter to her oncologist saying, could you please check her out and see if you think that there might be something going on that's related to POTS. So these are things that we can do to help our clients and help them more deeply.
And you are making a difference. Karen Ashforth, I can't think of a better way to start out our Lymphedema Awareness Month celebration, education. I just thank you so much for your time. Do you have any closing thoughts that you would like to leave our audience with?
Be curious.
Perfect. Be curious. That will guide you. The title was, why do some of my patients never really get better? And the good news is the people that are on this webinar today, all of our guests, thank you for joining us. Karen Ashforth and LymphaPress, we're here to make life better for people. We'd be proud to partner with you. Stay curious. And thank you all for joining us today. You will receive the link to the replay along with the slides. And I wish you all a happy Lymphedema Awareness Month and a great day. Thanks, Karen.
Thank you.
Bye.